Good day and welcome everyone to the Primary Care Resilience WebEx conference call hosted by Jill Gillis. My name is Karen and I'm your event operator. During the presentation, your lines will remain on listen only. If you require assistance at any time, please key *0 on your telephone and a coordinator will be happy to assist you. I'd like to advise all parties the conference is being recorded for replay purposes, and now I'd like to hand over to Jill. Please go ahead.
Okay, thank you, Corinne. If you can move to the next slide, please. And good afternoon, everybody. My name is Jill Gillis, and I am the Portfolio Lead for Primary Care within Healthcare Improvement Scotland, and I'm delighted to welcome you all this afternoon to the third WebEx in our series. We are running this as a facilitated WebEx by BT, primarily because of the large numbers. We've over 350 people registered to attend. I know a number of you are coming in at the moment. And we look for you to use the chat box to be able to have that conversation. So all of our lines are muted, but we're looking for you to have those conversations in that chat box. So please do put any of your questions, comments, suggestions within that chat box, and we'll pick them up throughout the WebEx. And if we don't pick them up through the session, we'll certainly pick them up later. So the focus of today's WebEx is medicines in primary care, and we have two topics that we're going to cover. So we're going to look at pharmacy first and also have a conversation around about pharmacotherapy. And those of you who were on our last WebEx, if you thought the speakers on that came from a sort of who's who in primary care in Scotland, I can certainly say you won't be disappointed in the lineup that we have for you this afternoon. Looking forward to a really good conversation around medicines in primary care. Next slide, please. Next slide. We'll just move on to this. So you had said, in our last WebEx, we had a rich conversation, and we wanted to use this forum to share and build our primary care learning system. And we'd said that we would prepare for you a report from our last WebEx and to share some of the conversations that you were having around about what's happened, what's gone well, where are things not going so well, what are we experiencing, what are some of the groups that we need to pay special attention to, and potentially some of the blind spots that have been identified. And we're building that learning system by capturing some of the conversation that's coming through the chat box and signposting to some of the resources that you're highlighting within that chat box. But we're also building that by sharing the slide sets and the resources that are being presented by those speakers. So we have listened to what you've been saying, and we'll continue to listen to what you're saying in that chat box and build that primary care learning system so that we are sharing our experiences as we move forward. Next slide, please. So we wanted to make sure that the agendas for these sessions are meeting the requirements for you, and so we did seek to understand what brings you to these sessions, and a large number of you had said that you wanted to really share with your peers what is happening, particularly around about recovery and remobilisation, and you wanted to also learn what's happening nationally. So we aim to kind of provide those opportunities, and we hope that we're meeting that need in today's session. Next slide, please. We also asked you which topics you would like to discuss in future WebExes, and medicines had come up strongly in the conversation in the last WebEx chat box, but a number of other topics have been suggested, and there's lots of conversation around about technology and sharing what we've learned from managing patients and using different technologies, and how we could and should move forward in relation to the use of technology and some of the evidence around about that, and how are we sharing and capturing those evidence and that evidence base. We also had a long number of conversations and a number of you wanting to discuss long-term conditions amongst another number of other things. So we will use these and we will use them to frame the topics for future WebExes. Next slide, please. So we'll continue to seek your views through our sort of evaluation surveys at the end of these, and based on kind of the availability of speakers, we will look to tailor our future WebEx sessions based on the insights that you are giving us. We're aiming to run a further WebEx in September and then a further one in November this year. But now, without any further delay, I'm delighted to hand over to our first presenter, Alison Strath, Principal Pharmaceutical Officer in the Scottish Government. So, Alison, if you hand over to yourself. Next slide, please.
Thank you, Jill, and thank you everyone for the invitation to come and speak today. It's been really nice to see some familiar faces appearing down the chat box as people have logged on, and also to see names of people I don't know, but nice to see trainees and a real mix of people, and I really welcome the opportunity for these sorts of WebExes as a way of exchanging, particularly across the multidisciplinary team, some of the issues that we're all facing. So it's great. I feel I've spent a lot of time, we talk a lot in COVID world about bubbles, etc., and I feel I spent a lot of time in a bubble which has been all around just reacting to things. So it's really nice to actually come and do my first virtual presentation since COVID started, and to engage with all of you, because I'm a great believer in that those of you closest to some of the problems that we face should be designed in helping us, should be involved in helping us design some of the solutions. This is a great opportunity for that exchange, and I really welcome it. And I think in a world where we're all having to learn to deal with telephone consultations and video consultations and technology and how we manage our kind of working day around that, I'm sure the opportunity to think a little bit broadly is really welcome. And my next slide, please. Thank you. Next slide, thank you. So I'm going to start just by addressing, I think, some of the activities that have taken place across the pharmacy profession in response to COVID-19. And so starting with community pharmacy, I think one of the things I really did want to flag is that I guess our community pharmacy network across the country remained open, really to be able to provide access to medicines and advice and support to members of the public and patients alike. So very much a first port of call for that access and advice, and an important role in that. We also worked to extend the existing minor ailment service, which allowed certain groups of patients to register with a pharmacy and use it as the first port of call for access to treatments for self-limiting minor conditions. There was a restricted group that were able to use that previously, over 60s, under 16s, people with income-related exemptions, etc. And we extended that to the whole of the population with the extension of care homes. And I'll come back to the care homes later on in terms of where we're going next. But that allowed community pharmacists to support general practice in terms of taking some of the workload around responding to self-limiting conditions and enabling people to access medicines as if they would have gone to their GP and got it free of charge on a prescription. So a very helpful kind of service, which I think supported certainly some of the kind of wider COVID-related work. Again, importantly, linking into not just in hours, but also out of hours. One of the benefits we have with the community pharmacy network is that they are obviously open often over Saturdays and in some cases Sundays and into late evenings. So we were able to work closely with NHS 24, local out of hours services, and also the COVID assessment hubs in order to think about ways of supporting patients again with access to advice or medicines where it was needed to do so, and some very clever working around how to support I suppose remote prescribing from these centres to enable patients or their representatives to go straight to a pharmacy to collect whatever medication may be required. And again, I guess community pharmacy has always provided a delivery service to patients. This isn't a funded NHS service, but I was really pleased to see the way that the network responded to actually helping in particular shielded patients, so those groups of patients that practices and others had helped identify as being people where it was important that we could wrap around good service delivery and ensure they could still get access to medicines while they were shielding. So a lot of work done by the community pharmacy network and by local GP practices working together to ensure that that happened and was supported locally. And finally, I guess just to say that there are a wider range of services provided in community pharmacy, such as access to emergency hormonal contraception, smoking cessation services, supervision of methadone, and community pharmacists and their support staff found ways of adapting these services to align with the physical distancing rules, along with obviously access to appropriate personal protective equipment, PPE, to help with that. So a range of things within that setting. Okay, the next slide, please. Moving on to kind of primary care, and I think the work that was done in particular in GP practices, but also more broadly across primary care with colleagues working to support practices and the wider primary care team. We certainly saw the move towards a virtual model for how we delivered the pharmacotherapy service. And I think where that particularly played some important parts, certainly at the early stages of our COVID response, was around looking at supporting early discharge of patients from hospitals, ensuring issues around medicines reconciliation, and working really closely, I think, to align with community pharmacy to ensure that we could support patients who were being discharged and ensure they had access to the appropriate medicines, or where necessary, followed up with the appropriate healthcare professional. Again, I think in terms of supporting those very early responses, I know many of my community pharmacy colleagues would say how busy we were in early March in terms of prescription volumes, partly because obviously people were keen to ensure they had access to medicines at a point when we were going into lockdown. So practices and in particular pharmacy teams within practices worked really hard, I think, to ensure that we could get access to appropriate prescriptions for people. And linking into that, I guess, how we use serial prescriptions. So these are prescriptions which are written that last for a slightly longer period of time, so 6 or 12 months, which are dispensed in instalments in the community pharmacy, and those instalments are set by the GP in terms of what interval they should be dispensed at, so 28 days, 56 days. So we saw an accelerated use of those serial prescriptions as another way of trying to improve, I think, how the medicine supply chain worked for patients and for practices, and also for community pharmacies. It might be worth saying that at this point that one of the things we got a lot of pressure about and continue to get pressure, rightly so, about is around access or the ability to electronically or in a paperless way generate these sorts of prescriptions. And it's certainly something we have very much on our horizon as being a priority to take forward. So we're doing quite a lot of work right now with our health and digital care colleagues to think about how we can appropriately find safe ways of allowing us to transfer the need for a prescriber to have a wet signature on a prescription to something that might move to an advanced electronic signature. So that will be something that hopefully we can come back and update this WebEx and primary care teams on in due course. And the last thing I wanted to say around primary care was really the work that was done to support a palliative care toolkit. So I think we heard a lot of information at the early stages of COVID about concerns, particularly with care homes, around just-in-case boxes and access to medicine for end-of-life care. So particularly thanks to Greater Glasgow and Clyde, who did a lot of work around thinking through some of the processes, but we developed a national toolkit to support within extant legislation that we couldn't change because it's reserved, but to find ways to try and enable an improved access to these medicines and to reduce any waste from that. Next slide, please. In terms of secondary care, again, at the start of COVID, a great deal of activity in terms of increasing the intensive care unit capacity, and that involved issues such as supporting early discharge for patients, and I guess a whole different way of working within the hospital setting with the kind of notion of red and green zones, which were either COVID or non-COVID related. And that required probably a fair bit of rethinking about how clinicians and other members of staff within the hospital setting were working. Also, we had some specific challenges around access to critical care medicines required to treat patients with COVID-19, so a lot of work to ensure that we could keep the supply chain resilient during these times, and a big thank you to staff in hospitals who worked really hard along with national procurement to ensure that worked. I mentioned supporting discharge already, so again, thinking about how we redesign patient pathways. There was a lot of work done, in particular around shielded patients, but also other groups of patients where thinking about how we could change the patient pathway so they could be managed in primary care and to avoid them having to come into hospital. So lots of work in particular in and around the kind of area of cancer where we made lots of decisions about how we use medicines differently to support that kind of way of working. And there were some really novel examples about how hospitals were supporting shielded patients, such as actually the hospital itself delivering medicines to that patient where it was appropriate to do so. And it would be remiss of me not to mention the work that's happened in our hospitals around clinical trials and potential COVID-19 treatments. And of course, we've seen 2 treatments so far come through that route, which hospitals in Scotland contributed to. So that was, first of all, remdesivir, and secondly, the use of dexamethasone, which we're all very used to as a traditional medicine in primary care, but obviously a kind of very important role within treating patients with COVID. Can I have the next slide, please? So just in terms of closing up, I just want to say a few words about what's coming next. And I guess I talked a little bit about some of the challenges we had around access to some particularly critical care medicines, but more generally, we're also approaching the EU transition period ending on the 31st of December. So we are doing a lot of work at a UK level because the supply chain for medicines works at a UK level to think about how we put some resilience into the supply chain. So that includes building a stockpile of critical care medicines, but also ensuring that we have kind of sufficient supplies of medicines in the UK as we enter the end of the transition period, and we ensure that we can access medicines appropriately during times when there may be some issues about cross-border changes to processes. We are also learning from what other parts of primary care have done about the use of NHS Near Me. So community pharmacies are now beginning to have that rolled out and are using that as part of their way of, I think, providing services slightly differently. And I think there's a lot for us to share and learn around the use of these technologies in the different settings. We're also now rolling out NHS Pharmacy First Scotland, and I know that colleagues from Community Pharmacy Scotland are going to talk about that later, so I won't go into any detail. But I would like to say is that this really is a progression on from our kind of minor ailment service development, and will actually include patients in care homes. So again, allows us to extend access to a wider group of patients in terms of treating minor ailments. We're doing quite a lot of work to think a little bit about how we, I suppose, augment the work of Pharmacy First Scotland in terms of, rather than using patient group directions for a number of prescription-only medicines, looking at how we build independent prescribing into the career pathway for community pharmacists so that we can actually have them prescribing first-hand rather than having to use some of the tools that are there for other purposes. And again, Reform Scotland during COVID-19 had a call for a greater or wider access to contraceptive services in primary care. So again, we're doing some work as part of the Women's Health Plan to look at the role of community pharmacists in providing a wider range of sexual health services. So, for example, bridging contraception and access to wider contraceptives where that's appropriate to do so. So that links in nicely with the work that they're already doing around emergency hormonal contraception access. I've talked a little bit about digital initiatives in terms of primary care and thinking about the issue of, I suppose, the taking away the requirement for a wet signature on prescriptions. We're also doing some work to think about links in with hospitals, so how we might also better support hospital discharge, and there's some really good work happening in Greater Glasgow and Clyde to explore those issues. And I guess finally, just to close by saying, I think there are some really great opportunities that have come through the remobilisation discussions that we're having around our response to COVID-19. So whilst it has been a very challenging time, I think it has opened up dialogues and allowed us to think about different ways of doing things that we might not have done if we didn't have this infrastructure and the need to do things slightly differently. So whilst I think it has been a really stressful time across the whole of the health service family, I think actually it also brings opportunities for us to think about how to do things differently going forward. So I know that you will all be instrumental in helping challenge some of our thinking around these issues. So thank you very much.
That's brilliant, Alison. Thank you so much. And hello, everybody. Michelle Watts from Scottish Government Primary Care here. Next slide, please.
So great to see everybody. Brilliant opportunity for sharing and learning, and great to see so much comments in the chat box. Please do keep them coming. It's good to have them. Next slide, please. So these webinars are a really good way of bringing together the whole primary care family, and the past few months have shown us like never before the importance of connecting and working together. And pharmacy and some of the stuff that Alison's been outlining and that we're going to get into today has been a real exemplar of that. Next slide, please. So thinking about our bigger agenda, early on in the pandemic, the King's Fund actually commissioned a survey about what people working across health and care thought were the key learning points from COVID. And I think these chime very much with what we've been doing in Scotland and particularly around our agenda today. Next slide, please. And so as we move into thinking about our speakers and hearing more about pharmacy first and the developments that have been going on across pharmacy, I think it's really important that we think about how we can build on this and work and connect together across not just the primary care interface, but across primary, community and secondary care as well. Next slide. As we go through our presentations today, please do keep coming in with the comments and keep some of the reflections that I hope chime with you from our colleagues in the Scottish Quality and Safety Fellowship Scheme, thinking about resilience and how being flexible and respecting each other's needs and keeping connected really helps to not just build our own resilience, but help us to move forward as we as we go through what is a huge agenda. As if we didn't have enough to do before COVID, we've certainly got plenty to do now, but such a great opportunity to think about how we do it differently. And so I'm going to kick off now and introduce our speakers and we go through a rapid run through some of the work that is happening across the pharmacy landscape. And our first speaker I'm going to introduce is Amanda Ray, who's the Head of Policy and Development for Community Pharmacy Scotland, as we move into this section to talk about Pharmacy First and its implementation. Please do keep the comments coming in the comment box. And over to you, Amanda. Welcome.
Thank you, and thank you everybody for the opportunity to speak. So next slide, please. And next slide again, please. And next slide again, please. Thank you. So this slide just gives you a bit of a brief summary of who Community Pharmacy Scotland are. I appreciate that many of you on the call will be familiar with this, but we're essentially a membership organisation representing community pharmacy owners and their teams, and we act as a single voice for these vital healthcare professionals as they deliver pharmaceutical care services to the people of Scotland on behalf of the NHS. And we're responsible for securing and continually developing a contractual framework within Scottish Government to deliver these services in line with the national and local priorities, and hence here today to talk about Pharmacy First. So next slide, please. So what do we want to achieve? Our goals really are to change how people can access and navigate care in Scotland, to see community pharmacy further integrated into the NHS as the first point of call for minor illnesses and pharmaceutical care of long-term conditions. Our experience of MASS, the Minor Ailment Service, gets us part of the way for minor illnesses. And we know from that we get the same clinical outcomes for patients versus any other setting. So when patients visit their community pharmacy, the clinical outcome is the same wherever they have visited. But clearly, community pharmacy is the most cost-effective place for us to see those patients. And the patient view of the service is overwhelmingly positive in terms of convenience, accessibility, and being able to drop in and access service from community pharmacists and their teams. Next slide, please. So why replace the Minor Ailment Service? So Minor Ailment Service has been hugely successful when measured against the policy aims it was trying to achieve. However, we know it can improve, and hence the change. It was inequitable versus other services. As Alison said earlier, the original service wasn't open to absolutely everyone, so that gave us an inequality. The impact and demand for other services is significant, but could be greater. The perception has drifted to the free medicine service, and we really need to get away from that. This is a service about consultation and advice, and not the free medicine service. Patients and professional knowledge expectations of the service are highly variable, and we saw some unwarranted local variations, so differences in the service and how it was provided across the various NHS boards, and that was confusing for patients. Next slide, please. So, key points for NHS Pharmacy First service. It's a new free NHS consultation service. Advice will always be given. NHS treatment may be supplied if absolutely necessary. So we may provide treatment on a prescription, or we may provide advice in the form of lifestyle changes, anything that would be appropriate to the patient's treatment. We may refer to another healthcare professional if that's the most appropriate course of action. And my colleague Catherine, who's coming on to speak from Scottish Government, will expand a bit further on this. So next slide, please. So what does the future hold? Although a significant advance in NHS service availability and accessibility for the people of Scotland at launch, this is just the first building block. The service will evolve over time, initially with the use of additional national PGDs to cover more conditions. And the kind of topics we could see there would be things like skincare treatments, minor skin infections, COPD. So there'll be a range of PGDs will come in at a national level to cover that. But we're also looking at a parallel strategy for independent prescribing to see a gradual development of practitioners able to respond to an even broader range of presentations and support patients with other services in a range of ways. And this will require closer multidisciplinary team working, and our aim eventually would be to have independent prescribers available in all community pharmacies. Next slide, please. So what next? So Catherine, my colleague from Scottish Government, will go into a little more detail on the specifics. But a recommendation here would be that you read the GP team guidance and use this to engage with your local pharmacies, who will be very keen to do similar with yourselves, because closer partnership working will need to become the norm as we all work together. And we would encourage early support of independent prescribing strategy in any way possible, because this will further support the appropriate shift in the balance of care across the health system. You know, the phrase, everybody working at the top of their licence, this is definitely a foundation for that, and we're really keen to see that across community pharmacy. Next slide, please. And that's the end of my session. Thank you.
That's brilliant. Thank you so much, Amanda. As always with these webinars, we go through things at pace, but please be assured, everybody, we're picking up all the comments that are coming into the comments box, and if we don't have a lot of time to get into them today, we will find ways of communicating and getting some answers back to you over the next few days. But you're certainly all part of a team, and closer partnership working is the norm. Absolutely brilliant. Thank you. And moving on now to Catherine. Catherine Aglen is a Scottish Government colleague who's been working flat out to think about all the practical implementations of rolling out Pharmacy First. And so without further ado, over to you, Catherine.
Thanks, Michelle. Next slide, please. So as Catherine Aglen, I'm currently on secondment. Actually, I'm a community pharmacist by trade, and also I'm the local Nest pharmacy tutor. But I have been seconded to the Scottish Government to work on this training. So next slide, please. So NHS Pharmacy First. Next slide, please. As Amanda said, it is a consultation service and encouraged to visit the public to visit their community pharmacy as the first port of call for minor illnesses and common clinical conditions. It can be accessed from any community pharmacy in Scotland. And for those of you, just as a note here, in working in dispensing GP practice, I would advise you to get in touch with your nearest community pharmacy, because now with Near Me and telephone consultations as an option, there may be ways of your patients accessing the service too, but you'd be best to discuss that locally and see how it's going to work for you. Again, as Amanda said, Pharmacy First is integration of the minor ailment service and the national PGDs that are in place at the moment, the UTI for women and the impetigo going over 2 years. But as the service develops, these additional common clinical conditions will be added to expand the range of treatments available in community pharmacy. And again, I think we'd be keen to get your thoughts and your feedback on what you feel would be beneficial for us to look at first. Next slide, please. So what does the service consist of? So the consultation with a member of the pharmacy team. On many occasions, as it is now actually with minor ailments, this is likely to be a trained member of staff who will be under the supervision of a pharmacist with a referral to the pharmacist if they require it. So breaking it down a bit, advice will always be given, as Amanda said, and this will help the person manage the conditions by themselves with appropriate self-care. So the service is intentionally designed not to set the expectation that a consultation will result in a supply of medicine. And healthy living advice is also a really important part of this conversation. If it's felt that the patient would benefit from some sort of treatment, there are a couple of options. So it can either be supplied on the NHS via the approved list, which I'll go into in a minute, or purchased via an over-the-counter sale. An important point to remember at this stage is that it can only be supplied either on the NHS or sold within the over-the-counter product licence restrictions. So, for example, hydrocortisone cream can't be supplied for anybody under 10 years old. If it was felt that the patient needs to see a different healthcare professional, then referral will be made. We may also supply a treatment in the interim to use depending on what that condition is. And every practice is going to probably have slightly different expectations of what could or what needs to be referred and how this happens. So this is where I would strongly encourage you to speak to your local pharmacies to discuss how this is going to work for you locally. Next slide, please. Let me now talk about eligibility. So registration is no longer required to access the service, and the person's eligibility is applicable at the time of consultation, so as they're standing in front of you or they're on the phone. And a person who's registered with a GP practice in Scotland or the Defence Medical Services, both on a permanent and a temporary basis, are eligible. And this also includes care home residents, which is a change from the old minor ailments. A person living in Scotland, this can include people homeless, gypsies or travellers, asylum seekers or dependents of asylum seekers, and people living in Scotland but registered with an English GP. There's also a small number of people who live in England but are registered with Scottish GP practice, and this group are also eligible because they have been eligible for minor ailments as it stands. A point to note here is that the current printed patient leaflet is actually at odds with this information. So the Scottish Government Legal Department tweaked some of the criteria after we'd gone to print, unfortunately. However, the online version is correct, and we'll obviously revise the next one. For the next print run, the printed version will be updated. Visitors to Scotland are excluded. And another point to note here that some health boards currently use the UTI PGD for tourists. So this will not be possible under the new service when it launches, as tourists don't meet the eligibility criteria. But the Scottish Government and CPS are working towards hopefully including them in the future, and any change to this will be communicated to you. Next slide, please. Going back to the approved list, so the NHS Pharmacy for Scotland approved list has been developed by the Area Drugs and Therapeutics Committee Collaborative and has been evaluated for therapeutic value for money and therapeutic effect. So the aspiration is to have a single list across all health boards to provide a consistent experience for the patients across Scotland and to make it easier for pharmacists to understand what they'll be reimbursed for. In the first version of the list, there will still be a requirement to refer to local health board formulas for which skin preparations to use. So you can be reassured that you should be supplying the same product as a patient would receive if they came to the GP practice. And the UTI treatment also slightly varies between health boards, so it's best to check what you guys are using locally. The plan is the approved list will be reviewed after 6 months of use, so things could either be added or removed. But again, it'd be useful to get feedback on its content as the months go on, and again, any changes will be communicated clearly to everyone. Next slide, please. In terms of promoting the service, so to help the public become more aware, there's several ways we're going to communicate to them. The patient leaflet was sent out to all community pharmacists and GP practices in March before lockdown. So hopefully you've still got boxes sitting somewhere in your practices. There will be social media activity and press releases planned for the run-up to launch. And you may have started to see some stuff already. On a more practical level, the signposting guidance for GP practice teams was sent by circular last week. So if you've not seen it, as Amanda says, this document is designed to help the practice teams to understand a bit more about the service and to also to guide you on who may be an appropriate person to refer to community pharmacy before Pharmacy First, along with some of the OTC guidance licensing restrictions. It's intended to be used as a starting point for delivering the service in a safe manner, and I would urge you to use this document as a tool to help discussions with your local pharmacies and your local practices, cluster practices, to agree for works for everyone, and therefore ensuring a consistent and efficient journey. So next slide, please. So that's it for me. I'd just like to hand back to Michelle now. Thanks, Michelle.
Brilliant. Thank you, Catherine. And the most important part, and certainly picking up through the comments box here as well, and also building on Amanda's comments, it's about that closer partnership working. And so really, really encourage GP practices in the clusters, community pharmacies, local primary care teams, sit down together and think about how this will work for you in your local circumstance, and what really matters to you in your local communities. And building on that, I'm going to introduce our third speaker of today, Jonathan Burton, community pharmacist and our current chair of the Royal Pharmaceutical Society in Scotland. Jonathan, over to you.
Hi everyone, thanks very much for inviting me on this afternoon. If we can just move to the next slide, please, and just the next one along as well, please. That's great. So my name is Jonathan, and I'm speaking to you today with my Royal Pharmaceutical Society hat on, but also as a practitioner. I'm a community pharmacist, and for many years I've provided the minor ailment service and the existing pharmacy first service to the patients using my pharmacy. I'm also an independent prescriber, and for the past 4 years I've been running a walk-in common clinical conditions service from my pharmacy, which slightly extends the range of conditions that I can assess and treat. That's mainly ENT and dermatology. So again, very much one eye on the development of our independent prescribing workforce and what they'll contribute. So the Royal Pharmaceutical Society, we're a professional membership organisation, and we represent and support pharmacists across Great Britain. Can you move to the next slide, please? Thank you, and I'll make this very, very quick because I do appreciate we're under a bit of time pressure today. So in terms of how the profession in general are viewing the move towards a new pharmacy first service, I think it's fair to say that walk-in services and community pharmacies have been going through a period of evolution over the past few years. And in Scotland, in terms of how those services are umbrellaed sort of as NHS services, we're probably ahead of the other home countries, but we're used to managing symptom presentations. And the original pharmacy first services that were introduced at individual health board levels, and I was involved with the introduction of 2 pharmacy first services in Forth Valley a few years back. They were really the first time that we really started to look at the consultation as the very central part of this model, rather than the sort of the transactional sort of handing over of medicines aspect, although that's still very important for a lot of these interactions. So the new pharmacy first service, it really brings the existing services together, but really does focus on that consultation model, and also starts to focus more on record keeping so that we can actually get better visibility over the hard work that our pharmacists and their teams are doing in community pharmacies. I think the profession generally is very welcoming of the new national approved list. I think that's a move in the right direction, and it helps the service to be manageable and equitable across the country. But there are still many, many challenges to overcome, and I'm keeping an eye on the sort of the chat function here, and I think many of the questions that are being posed are the right ones. Certainly my experience offering mass and pharmacy first and then NIP services, that the communication with practices can be very time-consuming and challenging. And certainly from an RPS point of view, we're going to carry on our lobbying around the access to records, not only from a read point of view, but also our ability in community pharmacy to write into patient records and to make sure that we don't have clunky cycles of paper and emails flying around everywhere. But we also have challenges to overcome in terms of COVID, distancing, in terms of cleaning, etc. Those are new challenges. But we also have the existing challenges in terms of operating NHS services alongside the traditional sale of medicines function that we have, which is very, very important still for self-care. Not everybody will require an NHS consultation, and I think we need to be mindful of that and how we balance this and how we message to the public about how best to use their pharmacy for their sort of minor ailments and common conditions needs. And I would like to highlight what some of the other speakers have said about independent pharmacist prescribers working in community pharmacies. You know, that transformation has already begun, and it's very, very important that we support that process. And that's certainly something that we're mindful of at the Pharmaceutical Society. If you can hop to the next slide, please. This is my last slide. I was just asked to cover some of the resources and support that as a professional Royal College type body that we're offering our members, and in certain circumstances the wider profession as well. These are just a few of the key things that I've sort of picked out of our sort of our buffet of things that we offer pharmacists and their teams. So we're mindful that we have a lot of reclassified medicines on the approved list, things that have moved from prescription status to pharmacy-only status, and are therefore sort of eligible to be supplied. That's been the case for many years with mass and we're working hard to make sure that we have guides for those medicines on our website. We have an extensive e-library and e-books that our members can download free of charge, and that includes a lot of texts and references that are very, very relevant to symptom assessment and the supply of over-the-counter medicines. We've also created a hub on our website regarding remote consultation advice. Obviously, we're moving at pace with NHS Near Me. I certainly use Near Me in my practice, and an increasing number of pharmacists will be doing that. So we've gathered all the resources we possibly can from all three of the nations within Great Britain to make sure that our members can access that easily, both for video consultation advice and telephone consulting advice. We also bring pharmacists together. We have an active mentoring platform, and we have an RPS local setup where we're starting to organise more online meetings with our members now, and we've been speaking to our members already virtually about the changes that they've experienced through the COVID period and how that's been affecting their practice, and the things that they would like to keep that have changed and the things that are causing them problems. We also have a COVID-19 hub on our website which gives lots of specific coronavirus-related advice. It's also very, very important to note that as RPS, we publish some of the key medicines information resources that are used in practice. In Scotland, we're very, very fortunate that on a national level we have access to Medicines Complete. So all your resources like BNF Online, Stockley's Interaction Checker, Adverse Drug Reaction Checker, that's all available to Scottish community pharmacists. We also have provided quite a lot of wellbeing support for our members through Facebook Live and other methods. And that's it from me.
Brilliant. Thank you so much, Jonathan, and to Catherine and Amanda for your contributions today. Lots of really good questions coming up in the chat box as well. And we don't have a lot of time today, so what we will do is pick these all out into a Q&A type summary, if that's okay, Jill, after today, because some really great stuff coming in through the chat box. And so without further ado, I'm going to move on to the second part of our presentation today. And over to Scott Jimison, who's going to lead us through some other pharmacy developments. Over to you, Scott.
Thanks so much, Michelle. Next slide, please. And again, yes, if you please continue to enrich the discussion, and as Michelle says, we will answer them as we can. Next slide, thank you. So I'm going to talk about pharmacotherapy, and I'm going to initially just talk a little bit about the background and then a traditional kind of QI model to how you could try to shape that in your localities to develop it. And to contrast that, I will then introduce my colleague Amy Robinson, who's the locality prescribing advisor from Dumfries and Galloway. Amy's an excellent speaker and will tell us about a different approach. There is not a right or wrong approach. We could pitch them against each other, but what it does show is that you need to invest in it to get out of it what you need. Next slide, thank you. So, and again, thank you. So I'm sure my colleagues will all be familiar on this call potentially with this division. For those of my AHP colleagues who are on the call as well, lots of nurses in there and ANPs. This was the quote by April 2021. Every practice will benefit from pharmacotherapy services, delivering the core elements, and that's those level 1 elements there. The levels of additional services will depend on workforce availability. My postulation here is I'm going to challenge that. I don't think workforce availability is certainly the only factor here at all. And there's a lot of things. Now, in Tayside, where I'm from, we had a lot of pharmacy technicians and pharmacists already embedded within practices. I'm aware that was not universal at all. And so some areas really had a lot of workforce issues to generate, and others, it was about what they did as well. Moving, next slide, please. So an approach that you could take is to implement the right wider systems, the right processes, and the right team, and that's what certainly in my head that I thought that's how we would try to get pharmacotherapy delivered. Next slide. To talk about the right wider systems, there needs to be a lot of other things in place if you're going to deliver pharmacotherapy. I took my job role nationally, executive officer of quality improvement. very much I saw this as a whole systems issue, and quality improvement investment in trying to get it definitely needs to be there. You need to think of the whole system, and unless you do have such things as prescribing pharmacists, discharges all arriving in a standard format, a vision formulary which was kept up to date every month, local formularies being up to date, MCR, CMS, serial prescribing, however you wish to phrase it, that needs to be used as much as possible to try and reduce down the signing signature, the wet signature workload every day. To be honest, supportive triage structures need to be there. Local technicians, pharmacists, cross-covering, and having access. I would champion my IT colleagues in the recent COVID emergency to be able to make sure that all pharmacists and technicians across DSED can cross-cover. We can all get access into each other's systems, and you can get into each other's practices without the requirement to be there physically. All outpatient communication changes. So when you attend a clinic, it needs to come into the practice in a standard format. If you don't do all those things, it makes pharmacotherapy much more difficult. And so very much in a QI approach, your first thing you need to look at is not what you're doing in the practice, but what everything else is going on around you. And all those other things have to be in place before you can start to change what you do in the practice settings. So moving on, next slide please. I do have some process maps here. I'm not going to talk through them all. I didn't intend to talk through them all, but it was to show you that very much if you want to deliver within the practice settings, the approach that we took is that you have to have kind of siphons off. And just to talk through this individual one here, when the outpatient communication arrives, we have a standard format letter that comes in from a hospital clinic, we then go through and initially they're looked at by the prescriptions administration in my practice, and we filter them off. And if it's on formulary and it's from a prescriber, that can directly be filtered off and completed and added to the medications, added as an acute and printed off for signing at that point. If it's not on formulary and it's not from a prescriber, it will then be workflowed down to a technician to next look at. Maybe they just didn't look at the right bit, or maybe they missed it, and that might be done. And then you move on again, and then it's to a pharmacist. And only then does a GP need to get involved. If the pharmacist can't do it, I'm lucky I've got a pharmacist prescriber who's a very experienced pharmacist, and we can get through all that, and the GPs are only actually signing the bits at the bottom if nobody can do it. Just to go through the next slides, just one by one in a slow pace, if that's okay. The next slide will be fine, thank you. Yep, we can do the same for medicines reconciliation for a new patient. Again, it can be done stepwise. And again, next slide. These slides are going to be shared, by the way, so don't worry about it. You will be able to look at it if you're interested. I know these process maps are not everybody's cup of tea, but and again, repeat prescribings can go through a same stepwise thing to make sure that the most appropriate person is doing them. And next slide again, please. Now, when you're talking about serial prescribing, it was mentioned earlier, this is my own practice. So this is the percentage of repeats on serial prescriptions. And please, whatever you do it gradually. Otherwise, you'll end up doing all your reviews in a oneer. So we go through those gradually, and we're gradually increasing them up. We're up now to 25%, and we'll continue to gradually increase them. We think we can probably get to about 50% if we're lucky. So just take your time and gradually increase them, but that needs to be in place if you're going to be able to reduce down the time that it takes for your prescribing admin to be printing off prescriptions every day. It's a waste of paper and a waste of trees, and MCR or CMS can be as safe if you have the right review systems in place around it. Next slide, thank you. Immediate discharges, you can do them exactly the same, just work through them in a stepwise process. And next one, next slide. And acute prescriptions, again, just doing it stepwise and getting each person to maximize and do what they can. We have my prescribing, my pharmacist kindly supports us as well in those. So we find how much of those we have to do. And if we move on to the next slide, acute prescriptions is the bugbear of my life. And that what I have done here is this is the weekly range of acute prescription requests in my practice. And you can see those big peaks around middle of March, which we felt in the practice, certainly that gives you the range, and the little triangle will give you the average for the week. So on average, we would need our pharmacists, if they were going to take over exclusively, to have between 30 and 40 slots in a day. As much as I have tried, we are struggling to reduce that. It's going to take a bit of work if we were going to reduce it. I don't know if it's possible. Either that or I just need another pharmacist to help support it, because at the moment they've got 15 slots and they certainly have not got the time to do 30, 40 slots as we probably need on an average day. Next slide. Medication queries, again, we have processes for those. These slides will be shared, by the way, so don't worry about it. But it's all process mapped to try and work out who's the best person to do things. It's just a normal QI approach, and you work together to try and improve these systems and make sure that there's different people to support it. Don't all being dumped on a single avenue. It's not going to make best use of everybody's time. Next slide. And therefore, that's what we ended up with, and for the right team. So we've divided all the tasks. The green things are the things that I've got process maps for, but we have a pharmacist for 7 sessions a week. I've got 8,800 patients, and we have 7 sessions. So one of our sessions, she either does another clinic or she does her locality lead role. I have a technician as well. Phenomenal technicians. Pharmacy technicians are a really big investment, and I would really encourage primary care training of technicians are a strong asset in your practice to foster and to support. We have a prescribing admin who supports this as well. They've been doing the job for 20 years in my practice. They're very, very good. And we have some GPs. We have 44 sessions of GP time in my practice, and we do other bits as well. This is a team approach. We have a healthcare assistant supporting the DMARDs, and we've got pending improvements. So the bits that I've not managed to deliver just yet within our team, we don't have the full polypharmacy reviews being supported by the pharmacist yet, but she will do some, which is really good. But I would like to get that more systematic and more process-driven, and certainly doing it more regularly, and specialist clinics by the pharmacist. So I'll stop there. That's our traditional approach to pharmacotherapy and how we could improve it within a practice. Not to say that it's right. It's not right. There is no right way. But I'm going to contrast that and look forward to hearing from Amy, who's going to give us another approach. And I look forward to welcoming her. Next slide. I think that's the last one. Yes, so pharmacotherapy is deliverable, but the workforce is only a small part. Collaborative approaches, pharmacotherapy collaborative, I won't talk about that just now. And delivering a QI approach will deliver pharmacotherapy far more likely to anyway. Amy, I'll hand over to yourself. Next slide. Thank you.
Thank you, Scott. Hi, folks. My name's Amy Robinson, and I'm locality lead pharmacist along with my job share, Leanne Drummond. And for the next 5 minutes, I'll give you a whistle-stop tour of the Wigtonshire Pharmacy Hubs. Next slide, please. Oh, next slide. For those of you who don't know where exactly we are, we're based in Stranraer, which is down in the very bottom southwest of Scotland. It's a small rural locality. We have a population of just over 28,000. We have 9 GP practices, 3 full dispensing, 3 part dispensing, and 3 non-dispensing. We are very rural, very remote. We go from the Mull of Galloway, Scotland's most southerly point, right round to the Isle of Whithorn, which is a road trip of 75 miles between our 2 furthest practices. And we're also 76 miles from our nearest acute services at Dumfries and Galloway Royal Infirmary. These logistics make delivering pharmacotherapy quite a challenge. Next slide, please. Why did we need a new system? Well, we were a very small team stretched across 9 practices, but also the wide geographical location. We were 2 pharmacists and a technician. We spent an awful lot of our time travelling. Over 25% of our day was spent in the car. We had limited availability of space and workspaces and surgeries. There's a lot of chopping and changing and booking appointments and going from one practice to the other in the same day. Significant recruitment issues. We have 2 2C practices. We have real issues with GP recruitment. We've got real issues with nurse recruitment, AHPs, etc., which means there's a lesser team to deliver on pharmacotherapy. I had lone working. We had lack of peer support. We often didn't see each other for days and days, just travelling around. We also now have a large remit to cover pharmacotherapy, CRES, LES, and all the other issues that come under the remit of a prescribing support team. We really needed to blue sky think. So what on earth were we going to do to deliver pharmacotherapy consistently over all of our practices with so many logistical differences and logistical problems? The idea that we had was to deliver pharmacotherapy from 2 offices in 2 GP centres, one at either side of the locality. Next slide, please. Great. We had remote access into the other practices. We used a variety of a team skill mix, upskilled and developed roles. We introduced a prescribing support worker role in Wigtonshire, which has been an absolutely key role in us being able to facilitate what we've done. We use the whole team. So basically, we have 2 large offices. The work comes in triaged by the prescribing support worker across the team that's in the office those days. So there's pharmacists, there's technicians, and support officers. We have increased the time that our GPs, DP, clinical pharmacists spend in patient-facing clinics. We provide peer support to one another. We provide supervised training. We have reduced our travelling significantly, and we've also reduced the amount of work that's going back to GP practices. I suppose the work gets filtered and work flowed around the team, and we've been much better able to cope with it. We all have had significant investment to pharmacotherapy, so our workforce has increased from the 2 pharmacists and 1 technician, but it's not a massive amount of workforce that we have. I've got some data from a snapshot audit we did in February. Next slide, please. There we go. We had 1 hub running for 12 months and 1 hub running for 6 months at this point in time, and I would say that the figures have increased since then because we had an issue getting access to 1 practice that week, so we were down a practice. So since then we've improved access by increasing our remote. We managed to do 81% of our IDLs and 65% of outpatient letters that came into all the practices. We had done 60% of our new patients' medicines reconciliation. We actioned 40% of acute prescriptions. We had 42% of our team time in total spent on pharmacotherapy, but we maintained a 15% what was our previous on LES and cost efficiency work. We saw patients for 15% of the total team time, but that's across our support workers and technicians too. So when we looked at it more specifically, it was 46% of our clinical pharmacist time was spent patient-facing. We reduced our travelling to 3% of our staff time, so we identified savings of 20 hours a week staff time on travelling, which was really quite significant for us. Next slide, please. What's been the workloads and benefits? Well, we've provided a 5-day service to all the practices that access the hub. We approximate that 5% of our queries go back to GP practices. We medrec, we phone every patient. We've got the capacity to do that. We have a weekly rota for our staff, so our staff are not shut in the hub all week. We have sessions, so everybody takes their turn. The pharmacist is always in the room and therefore provides close supervision for the other members of the staff, so the technicians are capable of doing an awful lot more than what they were when we started. We are carefully increasing our capacity in manageable chunks. There's an awful lot of project work goes on behind the scenes as well, so we've factored that into our time. It's been an amazing point of contact for our health and social care colleagues because we're in the office, in the healthcare centre buildings, we district nurses, midwives, etc., social work popping in all the time. We've really developed some super close interprofessional working relationships. We don't have any extra cover for holidays and sickness, but the hub can support that. If we don't do the clinic patient facing, the pharmacist can still cover the hub, so we get all of the level 1 stuff covered. We are able to combine LES and CRES and pharmacotherapy in one model. I don't have time today to go through all the hiccups that we've had along the way, mostly related to IT, but if anybody particularly interested, you can contact us at any point. Myself and Leanna would be very, very happy to talk you through. Next slide, please. How did we manage when COVID came about in March? Well, because we had large office spaces, we were able to work still with the social distancing requirements. We provided initially a limited service, but as that time has passed, we've been able to do more and more. We've increased our telephone consultations and we've also introduced Near Me, so we used it quite early on with iPads and continued to do some chronic disease medicines review. We used some of the extra time that we had to train our staff in different ways of communicating, so we trained them on using telephone consultations, using Near Me, but we also used the time to develop the technician role. We supported our community pharmacies, that was both physically and with sourcing, with helping them out with a lot of phone calls. we really did push on medicines care and review. We have increased our number significantly over the time. The best thing that we've done is trained the practice staff on Microsoft Teams. We provided them a PowerPoint presentation, and that really did help them identify lots of patients that we could switch over to CMS. And we also used some redeployed staff within our team to arrange patient deliveries of medicines to the rural and remote villages and those that were shielding. So for COVID, we've actually managed to work at quite a decent capacity over the amount of time, and we've learned an awful lot of lessons along the way. Next slide, please. So that's a whistle-stop tour of our pharmacy hubs. I appreciate that doesn't include a lot of the things that we've done, but we are very, very happy to take comments and questions or speak to you if you wish at a later date. Thank you very much.
Thank you so much, Amy. And yeah, there's certainly no one right model. Just to mention some closing remarks, Alison, and then on to Jill. Alison, how would you bring some of this together, Alison? Two very contrasting approaches, one just looking at the practice and the cluster level, one looking far more as a hub model. I don't think there's a right model, to be honest, but I think you need to do something. Hand over to yourself for some closing remarks.
Yeah, thanks, Scott. And I absolutely agree. And I think when we started thinking about pharmacotherapy, we started with there's no one size fits all. And in some ways, it was about letting people have the options to think about how best to develop this. And I can recommend anyone go down and visit Amy and the team, because I've been down myself, and it's really interesting to see how their model works. And I think one of the things for me is we've got an opportunity, I think, right now to reflect on what's happened and think about going forward. So I heard some really key things in the presentations about skill mix and thinking about that. And I guess there's something about having everybody working to the top of their license. So we probably made less progress, I think, in some of the areas where pharmacists could make a real impact in terms of medication review, polypharmacy, etc. And there's something to me about how we get that skill mix working to its full potential. And I think technology has a massive part in that, actually. So thinking about how we use technology to actually make sure we've got people doing the things that they're best placed to do with their skills and in the way that they work. And I think, Scott, there were some really interesting things from your slide set around some of those processes and thinking about understanding that mapping and who is best placed to do things. And that takes me on to collaboration. And I guess there is also that bit about in the model that Amy described, that kind of collaborative approach and thinking about whether that's from an individual practice, a cluster, or across a region. I do think we need to be, as we approach 2021, thinking about what are the things that we can learn, what are the things that we really want to ensure we get resource behind to help underpin us do things better and smarter. And that way we're ensuring that we're using all the healthcare professionals and all the rest of the skill mix within a practice setting to their full potential. And so I just want to give a wee plug, Jill, you'll be pleased to hear, to the work that obviously are doing through the Primary Care Collaborative for pharmacotherapy, because I think we will also get some really helpful learnings from that as in influencing our discussions and negotiations as we go into the kind of, what next for pharmacotherapy. So that's probably enough from me, and I'll hand over to Jill. Thank you.
Thank you, Alison, and just final thanks to kind of all of our speakers this afternoon. It's been a fantastic session with lots of conversation in that chat box, and we will produce a summary of that chat box and we'll prepare that, and where possible we will attempt to do a bit of a Q&A. I know there was a number of resources shared within the chat box, so we'll share the links to those resources within that summary. A number of the questions coming through around about the e-prescribing, the serial prescribing, and how can we increase the uptake, and lots of questions in and around that pharmacy first, and managing that patient demand, not potentially increasing that, but also how do we support patients in navigating that system. So I think we can certainly capture and begin to pull together a Q&A from that. The pharmacotherapy, really helpful to hear those two models, and Alison did give a bit of a plug for our collaborative. We had put that on pause at the start of or the mid-March. We are looking to write back out to those practices and clusters and that were part of that collaborative, but also to all that are interested in sharing that learning. We've realised we can work on a much wider scale now that we are working more virtually, so we would look to invite as many as wanting to participate in sharing the good practice, and we can provide support around about the process mapping, which Scott demonstrated really nicely. So we will get that out to you all. Just a final thank you to all of our presenters and to all of you for joining the session this afternoon. Thank you very much, and have a good afternoon, and we will see you all back in hopefully September for a further WebEx in our series. Okay, thank you. Bye.
Thank you. So, ladies and gentlemen, that concludes your conference call for today. You may now disconnect. Thank you for joining, and have a very good day.